Hello, everyone. So today, the topic that would be decided again an obstetric topic. So it is antepartum hemorrhage and hemorrhage in early pregnancy. So there are three things when it comes to hemorrhage in pregnancy or after pregnancy. The three terms that should be understood is anti or APH and hemorrhage in early pregnancy, and PPH. So you have to understand the meaning of all the three. So APH or antepartum, partum means giving birth, right? So or delivery or parturition. So partum means it is related to giving birth. So anti means before. So any hemorrhage that is occurring just before the delivery of the fetus or expulsion of the fetus is termed as antepartum hemorrhage. And hemorrhage in early pregnancy means it is related with pregnancy. That is, during the pregnancy, if there is any hemorrhage that is occurring. So there are few criteria to be called as antepartum and hemorrhage in early pregnancy. So we'll be seeing that. And postpartum hemorrhage, which was dealt in a different session. So it is after the delivery of the fetus. So it can be immediately after the delivery of the fetus, and it can be before the delivery of the or expulsion of the placenta also. So this is basically partum is related to the delivery of the or expulsion of the fetus. So these three conditions, the meaning should be understood and the difference should be properly known. So moving further, so the first topic we are going to deal today is antepartum hemorrhage. So let us see what is the definition of it. So it is defined as, again, hemorrhage means bleeding. So bleeding from or into the genital tract after the 28th week. So this is the criteria. After the 28th week of pregnancy, but before the birth, that means antepartum of the baby, and the first and second stage of labor is included. So don't think it is only before the labor. It can be during the labor also, but it is only first and second stage of labor, because with second stage of labor, the fetus is expelled. So after fetus is expelled, it is not called antepartum hemorrhage. It is directly called as postpartum hemorrhage. So this is very important. This can be a little bit confusing when it comes to the questions which is asked in competitive exams. So you should remember antepartum is bleeding into the genital tract after 28th week. It should be after 28th week, and the options will be given that way: after 28, before 28, or because partum is involved. So it can be like after 36 week or before 36 week. So this should be very clear. It is should be after 28th week, and it should be before the birth of the baby. And the 28th week is taken arbitrarily as the lower limit of fetal viability. Now, why 28th week? Because it is related to the viability of the fetus. So, which week is considered as when does the fetus become viable? It is only after the 28th week, and the incidence of the antepartum or APH is among almost 3% among the hospital deliveries. Next, what are the causes for antepartum hemorrhage? So the causes are divided into placental bleeding. So most of the 70% of antepartum hemorrhage is related with placental bleeding. So the problem is with placenta. So whenever an antepartum hemorrhage case is seen, so the most probable cause is lying with the placenta, and 25% is unexplained or indeterminate. That means the cause is not known, and this is excluding the placental bleeding and local lesion. The cause is not known in 25%, and 5% is extra placental causes. And those causes are usually related to the low cervix and vagina. So local cervicovaginal lesions, and they are cervical polyp, carcinoma cervix, varicose veins, and local trauma. So this is the broad classification of causes of antepartum hemorrhage. And when it comes to placental bleeding, now considering placental bleeding is 70%. What are the two main conditions that come up with placental bleeding? It is placenta previa and abruptio placentae. Now, this question, like how I usually say how adenomyosis and endometriosis is related to gynecology for favorite questions of competitive examination. When it comes to obstetrics, the two conditions which are of favorite questions which is formed or frequently asked question is placenta previa and abruptio placenta. So you can see these four topics is like with if you want to give a competitive exam and OBG is there, these 4 topics should be known, should be very thorough. So they are when it comes to gynec, it is endometriosis and adenomyosis, and when it comes to obstetrics, it is placenta previa and abruptio placentae. Now, the percentage which is contributed by placenta previa for the antepartum hemorrhage is 35%, and abruptio placentae is 35% again. So now here and it is known that placenta previa is more abruptio placenta is more common than placenta previa nowadays. And then here in further topics, placenta previa and abruptio placenta are the 2 topics which will be discussed in detail. And then because cervical polyps, carcinoma cervix, all that will come into gynecology topics. So let us focus on placenta previa and abruptio placentae. Now, so the first topic, coming to placenta previa, or the first placental cause, which is contributing to about 35% of total 70% of placental causes, placenta previa. Now, placenta, you know what is placenta. Previa means pre and present previously. So we will see what is the exact definition of placenta previa. So placenta previa means when the placenta is implanted partially or completely over the lower uterine segment. So this is not normal. This is not a normal implantation of placental site. No. So usually the placenta gets implanted in the fundus of the uterus where the implantation occurs. It is there. But what happens due to some cause? Due to some cause, it is implanted partially or completely, which is not in a normal position of usual placental implantation, which is the lower uterine segment. So over and adjacent to the internal os, and it is called placenta previa. Now, why it is called placenta previa? Because it is with the relationship of presenting part. So once the fetus is lying, the presenting part, once the fetus is lying, and if the head is here and if placenta is here, so you will get to know that it is a problem. It is a problem because the descent and the expression of fetus becomes difficult. So that is why it is called as placenta previa. That means previous to the presenting part of the fetus. Now, the term previa in front of placenta previa denotes the position of placenta in relation to the presenting part. Next, incidence of placenta previa, 1/3 of cases. That means in 10 cases, around 3 cases of antepartum hemorrhage is usually, that is 1/3 is usually by placenta previa, and 0.5 to 1% amongst the hospital deliveries. And in this 1/3 cases, or in the most 100% of placenta previa cases, 80% is by multiparous women. Multiparous women, and it is more in women who is giving birth after 35 years and in multiple pregnancies. So this placenta previa is usually not seen, not a usual condition in a primigravida. So it is usually seen in multiparous women. And etiology. Now, what is the cause for placenta previa? So there are theories. So the cause is not at all known properly. So there are around 3 theories which come up. One is dropping down theory, which is related to the direct implantation of zygote and persistence of chorionic activity and defective decidua. So these are the 3 theories related to placenta previa, related to the etiology, why placenta previa occurs, and big surface area of the placenta. So this is a more apt or more accepted cause for placenta previa, because when the surface area is becoming big, it tends to get pulled down to the lower uterine segment. Now, high-risk factors. This is very important, high-risk factors for both placenta previa and abruptio placenta, because frequently asked question in competitive exams. So it can be asked in the form of which of the following is not a high risk for placenta previa? Which of the following are high risk of placenta previa except? So you have to know all the high risk factors of placenta previa. First one is, as I said, in the incidence, multiparous women, it is more common. So the incidence is higher in multiparous women. So obviously this itself, multiparity becomes a high risk factor. Next, again, more than 35 years. So a woman who is giving birth and who is aged about more than 35, 36, 37, whatever it may be. So there, the risk factor, it is one of the risk factors for placenta previa. Next, history of previous cesarean section or any other scar in the uterus because of myomectomy or hysterectomy, and this is not hysterectomy. Okay, so part of the uterus is removed for whatever gynecological conditions it might be, or previous C-section. So there is a scarring which is there, and that becomes a high risk factor for placenta previa. Now, placental size and abnormality. When etiology was discussed, a big surface area was told. So placental size means increased surface area. That becomes a high risk factor. And abnormality of placenta. So some substantiate lobes. If this is present in placenta, it is a high risk factor. Smoking is a high risk factor, and prior curettage is a high risk factor. So one of the frequently confused option for placenta previa in the options is smoking. And in few questions, alcoholism is added. It is not there in the books, or it is not known to be causing or a high risk factor for placenta previa. So whenever a question comes that which of the following is not a high risk factor, so that should be added. And one option which comes up is poor nutrition. So these are all not factors which is related to placenta previa. So these high risk factors should be kept in mind because it is a frequently asked question. Next, pathological anatomy. So what are the conditions in placenta previa when it is seen? So how does it look? So the placenta is large and thin. Surface area is large and the thickness is very thin. And there is a tongue-shaped extension from the main placental mass, and extensive areas of degeneration with infarction and calcification may be evident because the implantation or the lying of the placenta is not in the original position. So the proper nutrition is not going to the placenta, and that is why these changes occurs. And placenta may be morbidly adherent due to poor decidua formation in the lower uterine segment. And when it becomes adherent, the condition which goes or a complication which occurs is placenta accreta or increta or percreta. So these are the pathological anatomical changes which are seen in placenta. Now, what are the changes seen in umbilical cord? The umbilical cord, the cord may be attached to margin. So these are the conditions of umbilical cord insertion. So usually it is central. Normal is it is usually central. So if it is attached margin, that is called as battledore umbilical cord insertion, or into the membranes, that is called velamentous umbilical cord insertion. So this becomes a etiological factor for the placenta previa. And the insertion of the cord may be close to the internal os, or the fetal vessels may run across the internal os in velamentous insertion, giving rise to vasa previa. So there is a condition, what is called as vasa previa, that is the fetal vessels running close to the internal os. And what happens, the rupture can occur. So along with the rupture of membranes, so that is called as vasa previa. And lower uterine segment, what are the changes? So due to increased vascularity, the lower uterine segment of the cervix becomes soft and more friable. Now, types or degrees. So degrees of placenta previa, depending upon the degree of extension of placenta on the lower uterine segment, it is categorized into various types. So first type is type 1, which is called as low lying. On the low, it is the placenta is on the only the lower margin is covered by the placenta and encroaches onto the lower segment, but not up to the os. It doesn't touch the os. That is type 1. And type 2 is marginal, reaches the margin of the internal os, but does not close or does not cover the internal os is type 2. Now, type 3 is incomplete or partially central placenta previa. It covers the internal os, partially covers the internal os when closed, but does not entirely do so when fully dilated. So only partially it covers the internal os. And the last type is type 4. It is central or total. And here the placenta completely covers the internal os even after it is fully dilated. A very complicated condition here, type 3 and type 4, because here the labor for it to happen becomes difficult. So here you can see, so this is type 1 or low-lying placenta. That means placenta is just lying low, and it can become a complication later on. But in type 2, it is the margin, it is marginal. The margin here you can see slightly it is covering the internal os. And type 3 is when the dilatation the dilatation is done, only then it is only partially covering. Otherwise it is covering completely. And type 4 is complete lying of placenta on the internal os. So these are the 4 types, and there comes degrees in abruptio placenta also. So you're not supposed to get confused between the two. So here the types are type 1, or just remember the other names. I've always emphasized on that. So type 1 is low-lying, and type 2 is marginal, type 3 is incomplete or partial, and type 4 is central or total. Next, dangerous, something called as dangerous placenta previa. So a question can be asked, which type will come under the dangerous placenta previa? So the answer is type 2 posterior placenta previa. Type 2 posterior placenta previa. That means type 2 is, it is marginal, and it is posterior presentation of placenta previa. So what happens? Curved birth canal. In curved birth canal, the major thickness of placenta, about 2.5 centimeter, overlies the sacral promontory. And what this does, when it is lying on the sacral promontory, this will diminish the anterior posterior. So this is the anterior posterior diameter of the inlet, and prevents engagement of the presenting part. So engagement is prevented, and this hinders the effective compression of the separated placenta to stop bleeding. So this is a difficult condition here. Now, placenta is more likely to be compressed if vaginal delivery is allowed, because when the head is entering, the descent is happening, it will compress. And this will become a complication, immediate complication during the labor, and more chance of cord compression, because cord is lying here, cord compression occurs or cord prolapse occurs. And the last two, especially these two, will produce fetal anoxia, because the compression will reduce the blood circulation. The cord is compressed, the placenta is compressed, so the blood circulation is entirely stopped for the fetus, and that will cause a fetal death. And that is why it is called as dangerous placenta previa. Why? Because it is posterior lying of placenta, and it is type 2 marginal. So the difficulty occurs when the fetus is descending, or when the fetus is undergoing the normal labor. So that is why this condition, it is not taken up for normal labor. Usually it is C-section. Now, cause of bleeding. So cause of bleeding. So in clinical feature, we will be seeing what are the clinical features. So mainly it is bleeding, the hemorrhage which is occurring. So as the placental growth slows down in later months and the lower segment progressively dilates, the elastic placenta sheared off the wall of lower segment. So this was discussed earlier in one session, where the third stage of labor, usually why placenta separates, in the mechanism of separation. So it is seen that when the labor is approached and the woman is under labor, what happens is placental growth will slow down, because now labor means the expulsion of fetus. The nutrition from the placenta is not sufficiently required, or it is not a necessity at that time, and after the fetus is expelled. And now because placenta is inelastic due to contraction and retraction activity of the uterus, what happens? Placenta is sheared off. It is inelastic, so it cannot it cannot elongate, or it cannot be, only if it is elastic it can elongate for the contraction and retraction. But because it is inelastic, it becomes, there is two things what happens: buckling and shearing off. So that is the normal mechanism of placental separation. So that usually occurs. Now, if placenta is low lying, that means what happens? The separation is becoming early. due to the contraction and retraction, and that is why bleeding is seen. So this leads to opening up of uteroplacental vessels and leads to an episode of bleeding. And as it is physiological phenomena which leads to the separation of placenta, I told you, mechanism of placental separation is physiological, but it becomes pathological here. Why? Because the position of it lying is not normal, and bleeding is said to be inevitable. However, the separation of placenta may be provoked by trauma, including vaginal examination, coital act, external version, or due to during high rupture of membranes. And why these becomes causative factors for bleeding? Why? Because it is low lying, and all these conditions is actually will put a pressure on the low lying placenta. The blood is almost always maternal. So the bleeding is usually always maternal. So although fetal blood may escape from the tone villi, especially when the placenta is separated during trauma, only in trauma condition fetal blood is involved. Otherwise, it is always maternal, and the bleeding is from the maternal surface. Now, spontaneous bleeding control. Usually, spontaneous bleeding control is caused by what? It is thrombosis of the open sinuses, mechanical pressure by the presenting part. So already presenting part is there in the lower uterine segment. So that will put a mechanical pressure, and placental infarction. So because of not proper nutrition, as we saw earlier, so what happens? The placental infarction occurs. Next, placental migration. Placental migration. So ultrasonography at 17th weeks of gestation reveals placenta covering the internal os in about 10% of cases. So this is a commonly occurring condition in placenta previa. What happens when a placenta previa is to be diagnosed? In 17 weeks of gestation, what happens when USG is done? It reveals that placenta is covering the internal os in about 10% of cases. So what in 37 week, again, the USG is repeated. So when the USG is repeated, it is seen that there is no placenta in the lower uterine segment. The placenta has somehow gone to the normal position in 90% of cases, and that is called as placental migration. So this occurs in a condition called placenta previa, where normally, without doing anything, the placenta is going back to its normal position. And lower uterine segment expands from 0.5 centimeter to 20 at 20 weeks and to more than 5 centimeter at term. So with the progressive increase of the length of lower uterine segment, the lower placental edge relocates away from the cervical os. So one of the, why it is occurring, why placental migration is occurring, one cause could be the increase in the length of lower uterine segment. And one more is due to trophotropism. Trophotropism, it is the growth of trophoblastic tissue towards the fundus, and that is trophotropism. So here what happens, the placenta goes to its normal position, and that is called as placental migration. And you have to remember it occurs in the condition called placenta previa. Placenta previa. Now, what are the clinical features? Clinical features of placenta previa. Again, I told you hemorrhage or vaginal bleeding is the most common thing that occurs. So the qualities of bleeding. That is very important, especially to differentiate with abruptio placenta. So here the bleeding is sudden onset and it is painless and apparently causeless and recurrent bleeding. Causeless and recurrent bleeding. So one condition which is painless and causeless bleeding which occurs in the antepartum hemorrhage, it is placenta previa. So preeclampsia may complicate a case of placenta previa. In majority of the cases, bleeding occurs before 38 weeks. And remember, after 28 weeks. And earlier bleeding is likely to occur in major degrees. There may not be any bleeding in central placenta previa until labor starts. Why? Because only because there the placenta is covering the entire internal os in central placenta previa, and what happens is once labor starts, the presenting part is putting pressure on the placenta only after labor starts. So that is the descent, when descent is occurring, and that is where that time bleeding is observed during the first stage of labor. Otherwise, it is in other conditions it is usually before 38 weeks. Now, on abdominal examination, the size of the uterus is proportionate to the period of gestation, and the uterus feels relaxed, soft, and elastic without any localized area of tenderness. And persistence of malpresentation. Usually, placenta previa is associated with malpresentation, especially breech presentation or transverse lie or unstable lie is more frequent with placenta previa. And the head is floating. Why head is floating in contrast to period of gestation? Why head is floating? Because engagement is not able to occur because of the low lying placenta. The persistent displacement of the fetal head is very suggestive of placenta previa. The head cannot be pushed down into the pelvis because of the low-lying placenta. And fetal heart sound, there is nothing related to the fetus. The fetal, until and unless it is a dangerous placenta previa, fetal heart sound is usually present unless there is major separation of placenta with the patient in exsanguinated condition. So these are the findings in abdominal examination. Now, there is something called Stalworthy's sign. It is usually asked in exam, and that is why it is, though it is not very significant in placenta previa, because sometimes in normal condition also this becomes positive. But one sign which can be usually seen with associated with placenta previa is Stalworthy's sign, and it is asked also. So what happens is slowing of the fetal heart rate on pressing the head down into the pelvis. So when a pressure is applied on the head, or it is pushed towards the vagina, when the head is pushed down, the fetal heart rate reduces. Fetal heart rate reduces. Why this is occurring? Because of the compression of the placenta and umbilical cord. The blood supply is reducing for a moment, and that is why fetal heart rate is reducing. And main important thing is it soon recovers promptly. So the fetal heart rate becomes normal when the pressure is released. And this is called a Stalworthy's sign, which is usually seen with low-lying placenta or placenta previa, and usually suggestive of presence of low-lying placenta, especially of posterior type. So we had discussed in dangerous placenta previa. Type 2 posterior type is the most dangerous presentation of placenta previa because it occurs, anoxia is most common with this, and anoxia means again related to fetal heart rate directly, and that is why this sign is mostly seen in posterior type of placenta previa, and it is called as Stalworthy's sign. It is asked previously in question paper, so I suggest aspirants to remember this. Next, vulval inspection, what happens? So only inspection is to be done to note whether the bleeding is still occurring or has ceased, and the character of blood should be noted. So here, extreme, examination is not to be done, a vulval examination. So the character of blood or the color of the blood to be noted if it is bright red or dark red, and the amount of blood loss to be noted, to be assessed from the blood stained clothing. And in placenta previa, what happens? The blood is bright red. It is not dark red, it is bright red. As the bleeding occurs from the separated uteroplacental sinuses close to the cervical opening and escapes out immediately. So escaping out immediately, that is in placenta previa. And vaginal examination must not be done outside the operation theater. Vaginal examination is only done after the pregnant woman is diagnosed with placenta previa and she is taken for a C-section. And their vaginal examination is done after in operation theater, as it can provoke further separation of placenta with torrential hemorrhage and may be fatal. So may be fatal, and it should only be done prior to termination of pregnancy in the operation theater under anesthesia, keeping everything ready for the C-section. So only then you have to do the vaginal examination. Now, how to diagnose a placenta previa? Painless and recurrent vaginal bleeding in the second half of pregnancy should be taken as placenta previa. So usually the cause in painless recurrent vaginal bleeding in second half of pregnancy is placenta previa, unless proved otherwise. And how to prove otherwise? One of the method is ultrasonography. Is the initial procedure either to confirm or to rule out the diagnosis. So in ultrasonography, the placental position is noted, umbilical cord insertion is noted. So all this will give a confirmation whether the placenta is low lying or is it in normal position. So localization of placenta is called as placentography. So in ultrasonography, the TAS, TBS, and transperineal ultrasound, color Doppler, 3D color Doppler, all these is done, can be done, or one of it can be opted to know where placenta lies. In MRI, for better diagnosis of placenta previa and placenta previa accreta. So accreta is a complicated placenta previa where the it is morbidly adhered to the uterus, and a clinical what is it, to know the lying of placenta, clinical examination is by internal examination, that is called as double setup examination, and direct visualization during C-section, and examination of placenta following vaginal delivery. So after the placenta is delivered, so you have to see for the placenta, whether any placenta is retained or how is the look of the placenta, all that is seen, inspected. So after the vaginal delivery, so that will be in mild types of placenta previa. Next, what are the complications of placenta previa? So why this condition is an alarming one? Because the complications are more, and that is why it is assessed. Usually placental lie is assessed, or placental implantation is assessed during pregnancy. What are the maternal complications? So during pregnancy, the maternal complications is again hemorrhage. So antepartum hemorrhage and malpresentation. So it is associated. It is like interrelated. If placenta previa is there, malpresentation will be there. And if malpresentation is there, it indirectly becomes high risk for placenta previa. And premature labor. And mostly when it comes to malpresentation, it is usually placenta previa followed by malpresentation, because placenta previa is lying in a different place. It is causing the fetus or it is making the fetus to lie in a different presentation. And death due to massive hemorrhage. If massive hemorrhage occurs, there is death of mother. And during the labor, so sorry, this is here. So during labor, what are the complications? It is early rupture of membranes and cord prolapse, slow dilatation of cervix, intrapartum hemorrhage, and postpartum hemorrhage, and retained placenta. So these are the complications in mother during labor. And puerperium. Puerperium, what are the complications? Sepsis, subinvolution, and embolism. So these are the complications in puerperium. Now, what are the fetal complications? Fetal complications is low birth weight babies, asphyxia, and intrauterine death. So IUD, and birth injuries and congenital malformations. So these are the fetal complications. Now, maternal and fetal morbidity and mortality from placenta previa significantly high. So we shouldn't take this condition as a simple one. So because the morbidity and mortality is significantly high with placenta previa. Next, we come to abruptio placenta. So now we finished placenta previa. Now, what is abruptio placenta? So as it is said, placenta, we know what is the meaning. Abruptio means abrupt or sudden. And there is some thing called as sudden separation is occurring. So that is abruptio placenta. So it is also known as the other name. Just remember, accidental hemorrhage or premature separation of placenta. So this somehow you can relate it with abruptio placenta, but accidental hemorrhage, suddenly you will relate it with the hemorrhage in early pregnancies, like various types of abortions. So that is why you have to remember one more name of abruptio placenta is accidental hemorrhage. Now, the definition of abruptio placenta is, it is one form of, we know, it is one of the cause for antepartum hemorrhage, where bleeding occurs due to premature separation of normally situated placenta. So one main difference with placenta previa and abruptio placenta is, in placenta previa, the situation or the implantation is abnormal. It is abnormal. Whereas in abruptio placenta, the situation or implantation or lying of the placental site is normal. Then what is the problem happening here? If it is normally situated, it is premature separation of placenta. So we know immediately after separation, what is followed? It is bleeding. It is massive bleeding that occurs after the separation of placenta normally or expulsion of placenta normally. So here it is premature separation. Then there is massive bleeding occurring. That is why it is falling under antepartum hemorrhage. And now the incidence, what is the incidence of abruptio placenta? It is 1 in 200 deliveries. And prenatal mortality is 15 to 20% and maternal mortality is 2 to 5%. So the mortality rate is high for a fetus than the mother. Now, varieties of abruptio placenta. So it is mainly 3 types are there. First is revealed type. Now, revealed type means following separation of placenta. Revealed means, as the name suggests, it is we get to know, it is revealing. So the bleeding we will get to know, or bleeding is seen outside. So following separation of placenta, the blood insinuates downwards between the membranes and decidua. Ultimately, the blood comes out of the cervical canal to be visible externally, and this is revealed type of abruptio placenta, and it is the most common type. So you should remember which is the most common type of abruptio placenta. It is revealed type. Next is concealed type. So as the name suggests, here bleeding is occurring, but we are not able to, or obstetrician or the patient is not able to see, or there is no visible bleeding. So the blood collects behind the separated placenta or collected in between the membranes and decidua, and the collected blood is prevented from coming out of the cervix. Collected blood is prevented from coming out of the cervix by the presenting part, which presses on the lower segment. At times, the blood may percolate into the amniotic sac after rupturing of the membranes, and in any of the circumstances, blood is not at all visible outside. So this type is a rare type. So most common type is revealed type. And there is something called mixed type. And here it is mix of both revealed and concealed. That means there is both concealed type and revealed type, and some part of separation has occurred. The blood is collected inside few parts, and that is concealed, and a part is expelled out. So that is revealed. So a mix of both concealed and revealed is mixed type of abruptio placenta. So broadly, it is 3 types: revealed, concealed, and mixed type. Now here you can see. So here it is a concealed type of abruptio placenta. So there is collection of blood, but it is not seen outside. Whereas this is a revealed type where the bleeding is occurring outside or visible outside. And here it is a mixed type. So because here it is a marginal, and it can occur that if it becomes severe, the blood can come out and it will remain. And here it is not a again, it is a concealed type. Now, what are the risk factors? As I told you, the risk factors for placenta previa and abruptio placenta are very important because it is asked. So risk factors, you have to remember the risk factors. And first risk factor is high birth order pregnancy with gravida 5 and about 3 times more common than in first birth. So high birth order pregnancy means there is no spacing between the pregnancies. So continuously the woman is getting pregnant, and it is more than 5 times. If it is more than 5 times, that means multiple times the lady is getting pregnant, and that is one of the risk factor for abruptio placenta. And advancing age of the mother, again, and here it is not specific, because in placenta previa it is very specific that more than 35 years. The incidences seem to be more specific for placenta previa. Here it is just advancing age of mother and poor socioeconomic condition. This was not there in placenta previa, whereas in abruptio placenta, this is one of the risk factor. And malnutrition, so poor nutrition is also one of the risk factor of abruptio placenta. Smoking, why? Because it will cause vasospasm and early separation of placenta. So that is one of the risk factor. Hypertension is also involved. Hypertension is also involved in pregnancy, is most important predisposing factor for abruptio placenta. Preeclampsia and gestational hypertension and essential hypertension are all associated with placental abruption. The association of preeclampsia in abruptio placenta is 10 to 15%. Next, what are the etiological factors or the conditions which become a predisposition, or what are the conditions that causes separation of placenta? So that is because exact etiology why separation occurs is not clearly known in abruptio placenta. These conditions could be the related conditions for separation of placenta. First is trauma, which separates the placenta, and sudden uterine decompression, short umbilical cord, and supine hypotension syndrome, placental anomaly, any anomalies with placenta, thick placenta, and folic acid deficiency, septate uterus or submucous fibroid, torsion of the uterus, cocaine abuse, thrombophilia, prior abruption. So there is a history of abruptio placenta. So that will become a direct risk factor or etiological factor for present abruptio placenta. So these are the factors. So it can be asked any of the above or one of the above. So just remember. Now, what is a Cavalier uterus? So there is something called as Cavalier uterus, and here you can see the bluish markings what is done. So we will see what is the Cavalier uterus. So it is also called as, I've put it in bold because you shouldn't get confused with the other names. So Cavalier uterus is also known as uteroplacental apoplexy. Uteroplacental apoplexy. So it is a pathological entity first described by Cavalier. So Cavalier means it is a person's name, and he described about it. So met with an association with severe form of concealed abruptio placentae. So here the blood is not visible outside, though it is a rare type. So if it becomes a severe form, it will lead to uteroplacental apoplexy or Cavalier uterus. So there is massive intravasation of blood into the uterine musculature up to the serous coat of the uterus. So because blood is continuously getting collected because it is a concealed type. So what happens? This blood gets intravasated into the uterine musculature up to the serosa, and the condition can only be diagnosed on laparotomy, because no signs and symptoms are seen outside. And naked eye features of the uterus, which has undergone this severe form of, uteroplacental apoplexy. So the uterus is dark port wine color. So we saw in the picture earlier that there was this bluish hue or shading, or that is because of this dark port wine color, which may be patchy or diffuse, and it tends to occur initially on the cornu before spreading to other areas, and more specifically it occurs in the placental site of the uterus. And subperitoneal petechial hemorrhages are found under the uterine peritoneum and may extend into the broad ligament, and there may be free blood in the peritoneal cavity or broad ligament hematoma. So this is called as Cavalier uterus. Next, microscopic appearance of the uterine muscles. So uterine muscles over the affected area necrosed, and there is infiltration of blood and fluid in between the blood muscle bundles because it is reaching till the serosa part of uterus, and most of the muscular dissociation occurs with middle and outer muscle layers. And serosa may split on occasions to allow the blood to enter into the peritoneal cavity, and that is why free blood is found in peritoneal cavity in few cases. The blood vessels show acute degenerative changes with thrombosis. So this is one of the condition which actually leads to shock. So one of the complication of abruptio placenta is shock. So this is especially when it becomes a concealed type. So Cavalier uterus is a severe form of concealed abruptio placenta. Now, clinical classification of abruptio placenta. So we saw based on the presentation or based on the separation of placenta and the blood collection, we saw there is 3 types, varieties, that is revealed, concealed, and mixed. But based on the degree of placental abruption, the degree of separation and its clinical effects, the cases are graded. So the grading is given. The grading are grade 0, grade 1, grade 2, grade 3. So grade 0 here, there are no clinical features. Absolutely clinical features are absent. And this grading is based on the clinical effects. And that clinical effects is directly related to the degree of placental separation or abruption. So grade 1 is occurring in 40%. So what are the features that is seen? Vaginal bleeding is slight. Uterus is irritable. Tenderness may be minimal or absent. Maternal BP and fibrinogen levels are unaffected, and fetal heart sound is good in grade 1. Now, grade 2, coming to grade 2, it is seen in 45%. So among the gradings, the highest incidence is grade 2. Highest incidence is grade 2. So 45% here, vaginal bleeding is mild to moderate. and uterine tenderness is always present, maternal pulse is increased, and BP is maintained, fibrinogen level may be decreased, and shock is absent in grade 2, and fetal distress or even fetal death can occur in grade 2. Grade 2 and grade 3, what happens? 15%. So this is a severe form. So bleeding is moderate to severe or maybe concealed. Uterine tenderness is marked. Shock is pronounced, and fetal death is the rule. So there is already fetal death. Now maternal complication should be controlled. So the association of coagulation defect or anuria may complicate in grade 3. So these are the gradings of abruptio placenta. Now, what are the clinical features? The clinical features depend on degree of separation of placenta, as we saw with the grading, and speed at which the separation occurs. So the bleeding, also the amount of blood concealed inside the uterine cavity. So these are the things that affects the clinical features. So it is the clinical features are divided by revealed and concealed type. So in mixed type, so it is given in mixed type, concealed features predominate. So that is why it is included in mixed type itself. Symptoms in revealed is abdominal discomfort or pain followed by vaginal bleeding. One of the differentiating factor of placenta previa and abruptio is placenta previa is painless causeless bleeding. There is no pain with placenta previa, whereas with abruptio, there is pain. And in mixed type, abdominal acute intensive pain followed by slight vaginal bleeding, and the pain becomes continuous. Character of bleeding, there is dark color bleeding, continuous dark color bleeding, slight to moderate, whereas in mixed type, continuous dark color, slight or blood-stained serous discharge. General condition proportionate to the visible blood loss, shock is usually absent. Here, shock is pronounced, and pallor is related to visible blood loss and revealed. And in mixed, pallor is severe and out of proportion to the visible bleeding. Features of pre-eclampsia absent in revealed and frequent association with mixed. And uterine height proportionate to the period of gestation, whereas in mixed, it is a disproportionate, enlarged, and globular. Why? Because there is collection of blood. And uterine feels normal with the localized tenderness, contraction frequent and local amplitude. And here in mixed, uterus is tense, tender, and rigid. Fetal parts can be identified here easily, and here it is difficult to make out because of the blood collection. And FSHS, fetal heart sound, is usually present in revealed, usually absent in mixed, because fetal death occurs usually, and uterine output is normal. And also, even though fetal heart sound might be present, it cannot be assessed or it cannot be known. And then uterine output normal and usually diminished in mixed type. So next is diagnosis, mainly clinical diagnosis, because the visible symptoms are seen, and this is not possible when it comes to concealed type. Ultrasonography or MRI may be helpful. So USG, early hemorrhage is hyperechoic or isoechoic. Acute hemorrhage is confused with a fibroid or a thick placenta. However, even negative findings with USG examination do not exclude placental abruption. So that is why when negative exam findings cannot exclude placental abruption, we have to correlate with the clinical presentation. Now, what are the complications? Complications of abruptio placenta in maternal. Revealed is proportionate to visible blood loss. So what are how the blood loss is occurring, and how based on that the complication occurs. So maternal death is rare and revealed, whereas in concealed, in the maternal complications are hemorrhage, shock, blood coagulation disorders, oliguria and anuria, postpartum hemorrhage, puerperal sepsis. And in fetal, revealed has fetal death is a complication, but it is 25 to 30% in revealed, whereas in concealed it is 50 to 100%. So if it is case of concealed abruptio placenta, very complicated condition for both mother and fetus. Now, very important exam perspective, because competitive exams, this is a frequently asked question, the difference between placenta previa and abruptio placenta. So reason, assertion, statements, these kind of questions, and except, none. So all these type of questions and match the following also can be asked with difference between placenta previa and abruptio placenta. So you have to be very thorough with this. So the nature of bleeding in placenta previa, as I told, it is painless, apparently causeless, and recurrent. Whereas in abruptio, it is painful, often attributed to preeclampsia or trauma, and continuous. And bleeding is always revealed in placenta previa. And abruptio, it can be revealed, it can be concealed, or it is usually mixed. So it depends on the type of abruptio placenta. And character of blood here in placenta previa is bright red, whereas in abruptio it is dark colored. And general condition and anemia, it is proportionate to the visible blood loss, whereas in abruptio, if it is a concealed especially, so the out of proportion in the visible to the visible blood loss and concealed or mixed variety. And preeclampsia is not relevant in placenta previa, but in 1/3 cases it is present in abruptio placenta. And abdominal examination, height of the uterus, proportionate height to the gestational age, whereas abruptio may be disproportionately enlarged in concealed type. Soft and relaxed feel of uterus in placenta previa may be tense, tender, and rigid in abruptio. And malpresentation is common in placenta previa because of the malposition of the placenta. The head is high floating, whereas abruptio has nothing to do with the presentation, especially of placenta and the fetus. So unrelated, the head may be engaged. And fetal heart sound is usually present in placenta previa, whereas it is absent, especially in concealed type. And placentography, USG, in, especially the placenta is seen in lower uterine segment. Lower uterine segment. Sorry. Lower uterine segment, and whereas in abruptio it is seen in upper segment. Vaginal examination, placenta is felt on the lower segment. In abruptio is not felt in lower segment. Blood clots should not be confused with placenta. So these are the differences, very important. You have to remember the proper differentiation between placenta previa and abruptio placenta and not to get confused. Now, vasa previa, as we discussed earlier. So the unsupported umbilical vessels in velamentous placenta, so this usually is associated with placenta previa, lie below the placenta presenting part and run across the cervical os. So the vessels are torn with the rupture of membranes spontaneously during the rupture of membranes. So color and what is helpful for the diagnosis, color flow Doppler, the TDS is helpful. And maternal fetal mortality is high in 50% due to fetal exsanguination. And detection of nucleated red blood cells, Singer's alkali denaturation test is done to assess vasa previa, and fetal hemoglobin ACT test is diagnostic. And fetal bleeding is often associated with fetal distress, and tachycardia, sinusoidal FHR tracing is done. So this is vasa previa. And one question that is asked is, which of the following condition is more common among the following? That is vasa previa, placenta previa, abruptio placenta, and there can be one more option. So usually the common type or common presentation or incidence is abruptio placenta. Abruptio placenta. Because vasa previa is a rare condition, it is a complication of placenta previa. Now coming to the next topic, abortion or hemorrhage in early pregnancy. Hemorrhage in early pregnancy. So only a few important points are covered in this topic. So let us see what is abortion. Abortion is defined as is the expulsion or extraction from its mother of an embryo or fetus. So this starts from the embryo till the fetus, weighing 500 gram or less when it is not capable of independent survival, and that is called as abortion. And this 500 grams, it usually corresponds to 22 weeks of growth of normal fetus or 154 days. So usually abortion commonly occurs before 22 weeks. Miscarriage means spontaneous abortion, and 75% of abortions overall, there are almost 7 types of abortions. So among that, 75% of abortions occur before 16th week. So usually before 16, these are all important points, exam perspective. So before 16th week, 75% occurs. And now among this 75%, 80% occurs before 12th week. So don't get confused. Out of 75% or which is occurring before 16th week, in this 80% occurs before 12th weeks. And what is called as recurrent abortion? The criteria for recurrent abortion is it should be 3 or more. So it is not like 2 or more. So this can be a question: 2 or more, 3 or more, 4 or more. So it is 3 or more consecutive abortion, and it should be before 20 weeks. And that is called as recurrent abortion. Now I have added few important points. So exam perspective, most common cause of spontaneous abortion is chromosomal abnormality. Genetic factors are defective germplasm, and most common cause of first trimester abortion first trimester abortion, that is before 12 weeks. The cause is usually chromosomal abnormalities, genetic factors, or defective germplasm. And most common chromosomal abnormality causing abortion, which is the most common chromosomal abnormality. It is usually aneuploidy, that means alteration in the number of chromosomes. And most common cause, it is trisomy 16. So just remember, trisomy 16 is the most common chromosomal abnormality causing abortion. And most common specific chromosomal anomaly associated with abortion is monosomy X, which is most common specific. It is monosomy X. And most common cause of second trimester abortion is cervical incompetence. So in first trimester, it is chromosomal abnormality, whereas in second trimester, the most common cause is cervical incompetence. And most common cause of recurrent first trimester abortion, trimester abortion is idiopathic. So here the chromosomal cause will not come in the picture. And most common chromosomal abnormality in recurrent first trimester abortion. That means, which is the most common chromosomal abnormality, and in recurrent abortion in first trimester, it is balanced translocation. Balanced translocation. So you have to remember these, because these are high yielding points for which can be asked as a question for competitive exams. Now, abortion are classified into spontaneous or miscarriage and induced or deliberate abortion. So in miscarriage, it is isolated or sporadic and recurrent abortions. And what are the types there? It is threatened abortion, inevitable abortion, complete abortion, incomplete abortion, missed abortion, and septic abortion, which is less common but very much serious condition. And in induced, it is legal, that is MTP, means medical termination of pregnancy. Illegal or unsafe, it is. And when illegal is done, what is the complication that occurs? It goes into a septic abortion. Now, here we are seeing. Okay, so here the type. These are the types I told you. Around 6 types are there commonly. And symptoms, uterus size. This is just to differentiate and for exam perspective, because frequently asked question from abortion topic. So just to differentiate. So threatened abortion. Symptoms is usually vaginal bleeding and there is pelvic pain, and uterus size corresponds to gestational age. So the age, gestational age, and the condition that is occurring is proper. The uterine size, and cervix, the external os is closed in threatened abortion. And when USG is done, fetus is alive, retroplacental hemorrhage is occurring. Next, inevitable abortion. Here, vaginal bleeding is seen, pelvic pain is seen. Again, it corresponds to gestational age, whereas cervix is open with palpable conceptus. And this is a spontaneous abortion where the fetus is expelled, and fetus is often dead, and there is retroplacental hemorrhage. Now, in incomplete abortion, vaginal bleeding is seen. It is the pelvic pain is not there, and the gestational age, uterus size is less than the gestational age, and cervix is open. Products of conception is partly retained and partly outside. That is why it is called incomplete. Now, in complete abortion, there is vaginal bleeding, trace or absent vaginal bleeding, and gestational age, uterus size is less than gestational age, cervix is closed in complete, and uterus. When USG is done, there is empty uterus. The fetus is not to be seen. And that means abortion is completed. There is complete abortion. Missed abortion, there is vaginal bleeding traces, brown color, and uterus size is less than the gestational age, and cervix is closed. And blighted ovum, or fetus with no fetal heartbeat, is missed abortion, and USG shows this condition. Now, septic abortion, which is a rare type, vaginal discharge is purulent, which is the associated features of sepsis, foul smelling with features of sepsis, and variable uterine size, and cervix is usually or external os is open, and products of conception is retained, maybe presence of a foreign body also, which is the cause for sepsis, free fluid in the peritoneal cavity of pouch of Douglas. So these are the broadly I've put it in a table, and it contains. So these are the questions can be formed as the external os of cervix is the following in inevitable abortion. So it can be the options can be open, closed, partly open, or open with palpable concepts. So you have to know these details. Now coming to MTP Act. So this is a part of FMT and here in OBG and also in SPM. So this is asked in various papers. So MTP Act means Medical Termination of Pregnancy Act, and it was done in 1971. And the indications for MTP Act is to save the life of mother, therapeutic or medical conditions which is threatening the life of mother. For that, medical termination is given, and then is done. Social indications, like for example, the woman has got pregnant and due to social various reasons, so that is the MTP is opted. And eugenic causes, that means there are chances that the baby which will be born will be with any defects, so there the MTP is opted. Now, who can perform MTP? A registered medical practitioner, and can perform MTP provided that practitioner has assisted in at least 25 MTP in authorized center having a certificate, or got 6 months house surgeon or internship training in OBG, or has got diploma or degree in OBG. And MTP can only be done in hospitals established or maintained by government or places approved by the government. And pregnancy can only be terminated on written consent of a woman, and husband's consent is not required. These are all probable questions that can be asked, and you should be able to answer. Pregnancy in minor girl, that is less than 18 years of age, or lunatic, that means with a psychiatric condition, cannot be terminated without the written consent of parents or guardian. And MTP is permitted up to 20 weeks of pregnancy. And when pregnancy extends beyond 12 weeks, opinion of 2 medical practitioners is required, and MTP has to be performed confidentially and reported to the Director of Health Services of the state in prescribed form. Whenever an MTP is performed, it should be reported to the Director of Health Services, and there is a format, and that should be produced to the director. So before that, there is one more condition, which is called as cervical incompetence. Cervical incompetence related to this. So you saw the most common cause of second trimester abortion. So here it is known by clinical diagnosis, and there is what happens is there is recurrent painless cervical dilatation, and spontaneous miscarriage, and this is usually seen in second trimester. So what happens, how to know this is Hegar's dilator is used, and when 6 number and 8 number is used, it is passed beyond. It usually doesn't pass beyond internal os, but here cervical incompetence, it passes beyond the internal os. So this is important. So which dilator passes beyond internal os? Hegar's 6 and 8 passes, and that is one confirmatory sign that the cervix is dilated and there is incompetency of the cervix. So in USG findings, so USG is done to see, and what it shows a short cervix, and the length which is less than 2.5 centimeter, less than 2.5 centimeter. And one more finding is very important, is funneling of the internal os. So you should remember all this, funneling of the internal os, and that is more than 1 centimeter. So these are the 2 findings which is seen in cervical incompetence, and it complicates. What is the one condition which it complicates to preterm labor, not pre-labor, it is preterm labor. And one more thing which is done is cervical index, something called a cervical index is done. So the normal value is equal to 0.32, whereas if it is more than 0.52, then we can confirm that cervical incompetence is there. That means the pregnancy cannot be continued here when cervix is incompetent. So that is why it is an important condition, and usually in second trimester abortion, chances of abortion are more in cervical incompetence. And what cervical index, how it is calculated, the funnel length -1 divided by the cervical length. The endocervical length, and in normal it is 0.32. If it exceeds 0.52, it is called as it will confirm that it is a case of cervical incompetence. Now, what is the treatment usually given? So, usual treatment that is given is cervical cerclage. So you should remember, cervical cerclage is given to which condition? It is cervical incompetence. And what is the age where it is given? It is what is the weeks where it is given? It is 14 weeks. So cervical cerclage is a procedure which is done to keep the cervical dilatation in place. So 14 weeks it is done, and this cerclage is removed. It is removed after 36 weeks. It is removed after 36 weeks, and there are two operations which is done. Operations which is done for the treatment of cervical cerclage. So one is Shirodkar's operation, and second one is McDonald's operation. Okay, so I know the handwriting is little here and there. So just remember this condition because the question is most probable from this condition. So cervical incompetence. Okay. So now we'll stop here. Okay. Thank you. Thank you, Focus.